Good afternoon, everybody. I am Maya Luria with TMC for Seniors, and today we are going to be talking about solutions for atrial fibrillation with Dr. Neil Gheewala. Dr. Gheewala is actually a structural interventionalist cardiologist, and he specializes in coronary artery disease and heart valve disorders. And so he performs quite a few cutting edge procedures, and he's going to be able to talk to you a little bit about that today. He has also included nearly 100 Watchman procedures. So the Watchman is some sophisticated technology to treat atrial fibrillation. And I think he's going to briefly speak about that, but also some other things that you can look for that can help to reduce your risk of a stroke associated with AFib. Dr. Gheewala has a passion for taking care of his patients with complex medical conditions who may need more than just traditional therapy. So I know that today we have people watching us on both YouTube Live and Facebook Live. Please leave your comments for us, and we will answer any questions afterwards in the comments. So I am thrilled to have Dr. Gheewala here with us. Welcome.
Thank you so much. We really appreciate you hosting this. This is an exciting time, especially with kind of expanding the therapies that we can offer patients with atrial fibrillation. So I want to go over, probably about 15, 20 minutes of sort of a broad overview of what we can offer patients. I'm just going to switch my screen here and let's see here. Where do I share my screen here? Okay, so thank you again for having me. So our topic today is to understand atrial fibrillation and what options and solutions we have here in 2020. We've come quite a long way from the ages of Coumadin and aspirin that people who had atrial fibrillation, or some of you who are watching, had in the in the 80s, 90s, and early 2000s. As mentioned, I'm the assistant director of the Structural Heart Program and also the associate program director for the Structural Heart Fellowships. And I am a member of Tucson Medical Center staff and a member of Pima Heart and Vascular. So kind of going over my talk here, I want to talk a little bit about what exactly is atrial fibrillation. Some of you watching may have atrial fibrillation, may know somebody who has atrial fibrillation, or maybe even concerned that you may have it. So we're going to talk a little bit about what it is, what symptoms you could have, and how do we treat this? Whether pills are right for me, or blood thinners, or if certain procedures are the right way to go for you. The nice thing about atrial fibrillation is that there is an individualized, personalized treatment that we can offer nearly every patient. So a little bit of background. So by the year 2030, which isn't that far away, it's estimated that 12.1 million Americans will have atrial fibrillation. In 2018, atrial fibrillation was mentioned in over 175,000 death certificates in over 25,000 people. That was noted to be one of their causes of death, and generally from stroke. Because women live longer than men, more women are affected by atrial fibrillation, which is a particular concern to us. So what I always like to do is I like to start with the basics. Let's talk a little bit about anatomy. And we try to make this a little bit as simplified as we can. But the heart itself has 4 chambers. We have 2 chambers at the top of the heart called atria, and 2 at the bottom called ventricles. The right side, of course, is called the right atrium. The left side is called the left atrium. For the purposes of discussion, we're going to talk a bit about the left atrium. The left atrium is where the pathology of atrial fibrillation begins, and also where oftentimes blood clots form. 90% of blood clots that are in the heart are oftentimes in a structure in the left atrial appendage, which is part of the left atrium. The 2 bottom chambers here, the ventricles, they are the main pumping chambers of the heart that are often affected when you have heart attacks. So what exactly is atrial fibrillation? So atrial fibrillation is an irregular heartbeat. You often hear that term thrown around. And sometimes if you take your blood pressure cuff at home, sometimes it says to check with your doctor because your pulse is irregular. That's something that can be associated with atrial fibrillation. And instead of the actual chamber, the top part of the heart, as you can see here, sometimes sort of squeezing fully, it fibrillates, and the blood tends to pool a lot more than it would if the blood was fully ejected out of the chamber. So that pooling of blood in the heart can cause stasis, and it can form a blood clot in the left atrial appendage. So here on this diagram here, this is the left atrium here, and this is what they call the appendage. The appendage is very similar to the appendix that we have. Many of you who are watching or may know somebody or yourself may not have an appendix, and people do just fine without an appendix. This embryologically is very similar to not having an appendix, or to having an appendix. This is where a blood clot can form, and this is the site where blood clots can actually be ejected out of the left atrium and actually go to the rest of the body, causing what was most feared, which is a stroke. So this is an animation here looking at atrial fibrillation. Just kind of think about how chaotic the rhythm is. So if you look at the normal heartbeat, we call a normal heartbeat oftentimes is called sinus rhythm. That's the technical term that we call for a normal heartbeat. When you have an irregular heartbeat, most commonly that is called atrial fibrillation. If you look at the diagram here under normal heartbeat, you can see here in yellow at the top that you can see that these chambers are beating in synchrony, where the top chambers beat, then the bottom chamber, top, bottom. But you can look over here in red, where there's chaotic beating of the upper chambers, which leads to chaotic beating of the bottom chambers. And that leads to the heart being a lot more inefficient, being much less efficient than it should be. So when I say that we want to control the rhythm, this is what we're talking about. A rhythm is kind of the way, it's kind of marching to the beat of a drummer. You can march at a drummer that's in sync, or you can march to a drummer that's out of sync. It's a lot easier to do it with somebody who is in sync. And that's when we talk about sinus rhythm or a normal heartbeat versus an irregular heartbeat. So what are the symptoms of atrial fibrillation? What's scary about atrial fibrillation is there's some people who don't even know it. I've had patients that come to my office and oftentimes tell me that they feel just fine and haven't had any symptoms at all. We do an EKG and we find that they're actually in atrial fibrillation. So that's why it's very important for you to see your internist or even a cardiologist to have at least an annual EKG to make sure that there isn't atrial fibrillation that we're missing. Sometimes the first time we find out somebody has atrial fibrillation is when they present with a stroke. And our hope is to always get ahead of that. Now, for those who do have symptoms of atrial fibrillation, that can lead to palpitations where you feel a rapid fluttering or pounding their chest. For some people, they just feel really fatigued and tired. For some people, it's lightheadedness. In some extreme cases, they can feel short of breath or have chest pain that may not be related to a heart attack, but just because their heart is beating so irregularly that patients can often feel these symptoms. And this may be some of the first signs that there's more to come. So why is atrial fibrillation bad? And by the way, when I say AFib, that's just a short term for atrial fibrillation. So what we worry about is stroke, and stroke. That's what we worry about. So oftentimes or I would say many times, we put patients on blood thinners to reduce their risk of stroke. Other reasons why atrial fibrillation is bad is because they can be symptomatic from it. As I mentioned, some people can be fatigued, feel short of breath, have palpitations that really bother them, or have chest discomfort. And for some, in some extreme situations, it can also lead to weakening of the heart. But primarily, the stroke risk is what we worry about first. Now, getting to the left atrial appendage. So as I mentioned, this structure is attached. So this is a left atrium here. And this is a site where clots form within the left atrial appendage. Now, what we know is that the left atrial appendage is about as unique as a fingerprint. Mine versus yours or your loved ones or anybody else who's watching or any friends of yours, all of our appendages are different, and they're about as unique as we are as individuals. As you can see here, over the last decade, we've started to perform more and more CT scans on patients for whom we're trying to study the left atrial appendage, and we find that we have all these different morphologies. Somebody's looking like a hook, somebody's looking like a seahorse, somebody's looking like a finger or a knob or an arrowhead. And I've heard also, we've heard the term broccoli. You can name it for just about anything you want to name it, but there are so many different morphologies that make an individual. So this is why I think individualized treatment is very important for patients with atrial fibrillation, because the appendage is about as unique as we are. Now, I think that knowing your stroke risk is very important. So, like everything, we have to have calculators. You have mortgage calculators, you have all sorts of calculators out there. The CHADS VAS score is one of those ways to determine stroke risk. So, we used to use an older calculator called the CHADS score. Um, in about 10 years ago, there was a paper that came out that showed that if we expand some of these criteria, we're able to better risk stratify patients who have atrial fibrillation. So here you can see there's a list of things here. Kind of, if you look at the acronym, CHADS-VASC. So, and this is the CHADS 2 VAS score. Every one of these is associated with a score. So if you have congestive heart failure, that gives you a point. High blood pressure or on a medication for high blood pressure gives you a point. Being over the age of 75 gives you 2 points. Diabetes, having had a prior stroke, any vascular disease, being between the age of 65 and 74, or being a woman. Those things all give you a point. And what we do is we like to, we add up all of these points. And as you can see here, as these numbers increase, the risk of stroke also increases. So if you meet all 9 of these criteria, you have a 15% annual risk of stroke, which is very high if you don't use any blood thinners. So as I mentioned, how do we treat these things? Atrial fibrillation, there's 2 things that we think about. One is stroke prevention, and the other one is symptom prevention if you have any symptoms. So oftentimes, the first priority being stroke prevention, we like to use blood thinners. What are some examples of blood thinners? Coumadin or warfarin, which is the oldest, least expensive, probably the most studied drug out there. If you know patients who, or friends or family or loved ones who are on Coumadin, you know that those require nearly weekly blood tests, and you have to have certain dietary modifications to make sure that your blood stays thinner, it stays at the level that you want it to. Over the last 10 years, we've also developed newer drugs, which are essentially like a pill that you take and you don't have to check any blood tests. One of those is called dabigatran or Pradaxa, apixaban, or also known as Eliquis, or rivaroxaban, also known as Xarelto. All of these drugs, the latter 3, are certainly more expensive than Coumadin, but patients like these drugs because they can often take it and not have to worry about that. Worry about checking their how thin or thick their blood is. Now, aspirin comes up a lot, and aspirin, a lot of times we like to say, we often colloquially call aspirin a blood thinner. It really isn't a true blood thinner. The technical term is that it's an antiplatelet. So it has very weak, mild blood thinning abilities, for example, for prevention of heart attack if you've had one, or for keeping stents open if you have any stents. But in terms of actually classifying it as a true blood thinner, which will prevent a stroke, the effect is very mild in terms of reducing your risk. Now, if you're 35 years old and don't have any issues and have atrial fibrillation, well, gosh, your risk of stroke is really, really, really low. So sometimes in those cases, we do place patients on aspirin. But generally speaking, if you are certainly over the age of 50 or definitely over the age of 65, and you meet any of those criteria that I spoke about, then a discussion with your cardiologist about a blood thinner would be appropriate. In general, what I would say is if you could take a pill and you can reduce your risk of stroke, a tablet's always going to be better than any procedural indication that you can have. And there are patients who live the rest of their lives with no reduction in their quality of life by taking a blood thinner. Now, what problems can blood thinners have? It's bleeding, bleeding, and bleeding. Now, some people can develop stomach bleeds, or sometimes if you can have bleeding as a consequence of a fall, such as if you fall and you bumped your head and you bleed in your head. So blood thinners are great when they're working just fine. But when blood thinners start to have problems, that's when you have to have the discussion with your doctor about saying, maybe are there alternatives of things that I can do for myself to equally prevent a stroke? So what do we do in patients for whom blood thinner is not a good idea? Well, up until about 2015, we really didn't have a great option for patients. I remember when I was training in residency up in Boston, we had patients who were in atrial fibrillation, and they came in with a fall and they had been on a blood thinner, and we were afraid of the consequence of them being on a blood thinner in the future. So we would start those patients on aspirin, and we hope for the best. Now we can actually close those left as of March of 2015. We're able to actually close those appendages with a procedure called Watchman, and you may have seen those commercials on television. So just getting back to the stroke risk with atrial fibrillation. So if you're watching here, go to a website called sparktool.com. It's SPARC, sparktool.com. And you can input your age and risk factors and calculate your risk score. So very similar to what I did, what I pointed out earlier, it has a really nice calculator where you can just input your information. And this is just kind of a figure. So this is kind of an example. So let's say you had a 75-year-old female who was otherwise healthy, had no other issues. That patient's CHADS VAS score will be a 3. So she would receive 2 points for being over the age of 75 and 1 point for being female. And so at that point, for this individual, if she had atrial fibrillation, then there would be a 5.4% annual risk of having a stroke. 5.4%. Now, if she would decide to take aspirin, didn't want to be on a blood thinner, then that risk score would go down to about 4.2%. But let's say that this patient was a good candidate for long-term blood thinners. Then Coumadin or warfarin or Pradaxa or rivaroxaban, all of these drugs would be an acceptable option. And as you can see, the risk of stroke does not become zero when you start blood thinners, but compared to a 5.4% down to a 1.8%, or even some cases a 1.2% reduction of stroke risk, are pretty good odds and are excellent ways to prevent a stroke with just a tablet. Now, so in whom is a blood thinner a bad option? So those who've had prior bleeding events, those who have had a fall or high risk for having a fall, for example, patients who walk with walkers, patients who've been non-compliant in the past with blood thinners, or those patients who choose that they just don't want to be on a blood thinner or at a high risk for a stroke. So for those patients, a very good option for those patients is Watchman. This is a procedure that essentially involves going from the groin up to the heart and actually placing a plug in the appendage so that no blood gets into the appendages and no clots get out. This is essentially placing a screen so that way the device would actually prevent any pooling of blood in the left atrial appendage. This is a very safe procedure and a procedure that's been done in over 100,000 patients in the United States. Here at Tucson Medical Center, we have been in the top 20 in terms of devices implanted and had just had our 500th Watchman implantation just not too long ago. The newest generation of devices come out and is even safer than the old generation of the device and is a very soft nickel and titanium cage with a fabric over it, which essentially would allow your own skin or the skin inside the heart called the endothelium to grow over it over a period of time. The catch is with this particular procedure that you would need to take blood thinners at least for a short period of time for about 6 weeks. So this is an example of a patient who required Watchman. So in general, we're one of the few centers in the country that end up using a CT scan to model patients' hearts. And I'm one of those proceduralists that likes to have all the information I can possibly have before we get in there. And so what we're able to do is create a three-dimensional rendering of this. So as you can see here, this structure here is the appendage, and this essentially is something that we have been able to reproduce based on the CAT scan that this particular patient had. But what this does for me is allows me to plan my procedure in such a way that I know exactly what my angiogram will look like. And I can then decide before I even do the procedure what particular size of the Watchman device this patient would need and what approaches and what challenges I would have. And it also helps with informed consent for patients to also be able to see what their own appendages look like and also to understand the risks and benefits that are unique to them. As you can see here, this is a three-dimensional rendering of the appendage. And you can see here that allows us to also determine what direction this is going, if it's going toward the front or the back or horizontally. So this is an example of a Watchman procedure that was done not too long ago here at Tucson Medical Center. So here on this diagram here, this is actually an angiogram of an appendage that looks pretty similar to that CAT scan. And this is after the Watchman. So as you can see here, the Watchman procedure here on the right side of your screen actually has the device implanted. But as you can see, when I inject X-ray dye into that, there is no dye going into the appendage at all, which is the purpose of the procedure, to make sure blood does not get into the appendage, so for clots to form. And this is a one-time procedure, and and essentially, I would say, is very similar to like not having an appendix anymore. We don't take anything out, but essentially plug it up. So we just talked about the ways to reduce the risk of stroke. Now we have to talk about symptoms. So in general, if patients, once patients are on blood thinner or have a Watchman, whether they're in atrial fibrillation or not, if the patients have no symptoms, we generally like to treat symptoms. Now, if they're going in and out of atrial fibrillation from a normal rhythm and they're having a lot of symptoms from this, then we do consider what's called a rhythm-controlled strategy. And the strategy for that is essentially putting patients back in that normal rhythm that I was talking about earlier called sinus rhythm. And this oftentimes can be achieved through pharmacologic means by taking certain medications that can keep people in a normal heart rhythm. But if that doesn't work, then we can always consider what's called an ablation, which is performed by an electrophysiologist who is a cardiologist specializes in heart rhythm disorders. So as you can see here, this is kind of a schematic of how the catheter ablation procedure works. So this essentially, as you can see here, the short circuit occurs here in the left atrium, and the purpose of this procedure is to break that short circuit. This can be done by freezing the short circuit or microwaving the short circuit. It's a very, very safe procedure, and it's performed, as I mentioned, by an electrophysiologist. Excellent. So as I mentioned, we're talking about catheter ablations. So as I mentioned, this is done by an electrophysiologist and needs to be done using catheters go from the groin up to the heart. Again, it's done primarily for symptoms, and it's generally about 60 to 70% effective. So you do have to take blood thinners after this. This is not a solution for completely getting rid of atrial fibrillation. So this is the conclusion of my presentation. So thank you very much for joining me. I really appreciate that. If you have any questions, you can certainly email me or you can contact my office, and I'm certainly happy to talk with you. But I think what's most paramount is having a discussion with your primary doctor or your own cardiologist about what may be right for you if you have atrial fibrillation. Thank you.
So thank you, Dr. Gheewala, and I apologize. Sometimes Wi-Fi, that happens, I guess. I do have a couple of questions that came up during your presentation that I'd like to see if you can help us with.
Absolutely.
So one is we were asked about tachycardia and how it relates to AFib. Is it something completely different?
Yes, that's a great question. So tachycardia is a condition where your heart rate is elevated. And that can be from a number of causes. So when you have atrial fibrillation, because you have an irregular heartbeat, oftentimes you can get an elevated heart rate. And if you have an elevated heart rate, that is called tachycardia. Tachycardia is kind of like saying car, right? But there are different makes and models of those cars. So you can have, a Chevy Impala, or you can have a Toyota Corolla, right? But so tachycardia is kind of a catch-all term, like saying car. But atrial fibrillation is like saying, okay, this is a Toyota Corolla, and this is and it's very specific to it. But so tachycardia just means an elevated heart rate.
Okay, great. And would AFib ever require a defibrillator?
Atrial fibrillation itself does not require a defibrillator. However, if you have had atrial fibrillation that has essentially, if you've had a high heart rate for a long time, and again, some patients have been completely asymptomatic and have no symptoms at all. If you have had a weakening of your heart muscle, then as a consequence of that, you may need a defibrillator. But just because you have atrial fibrillation itself does not necessarily mean that you need a defibrillator.
Well, and here's a follow-up question. Does AFib shorten your life expectancy necessarily?
Not necessarily. No, it does not. There's plenty of people who've been living with atrial fibrillation for 20 or 30 years, but the most important thing is stroke reduction. So being on that blood thinner itself can do that. Now, the consequences of blood thinners, of course, are of paramount. And as I mentioned, in the past, patients who had problems with blood thinners did not have options. But now that the Watchman procedure has been done, or over 100,000 patients have been shown to be safe. That is an option for those patients. So in general, and again, there are always specific situations, but in generally speaking, it does not reduce your lifespan itself.
Okay. And then the last question that I have is, are there any shape of atrial appendages that are more or less likely to be beneficial?
Oh, in terms of your stroke risk, so we do not know. We think that sometimes smaller ones that are curved, funny, kind of looking like a seahorse. Sometimes, we look for big blood clots up here, but if you have a blood clot at the tip, we may not appreciate that as much. So there has been some postulated that maybe a smaller one that's angulated properly may be a lower risk. But I think there's a lot of different factors. In some patients who have atrial fibrillation related to a heart valve condition, it doesn't matter what size your appendage is because your risk of stroke is higher. But if you or if you have a leaky heart valve, sometimes that may wash the appendage. So I think it's really difficult to say that there are certain situations where that risk of stroke is different. So in general, we say atrial fibrillation, regardless of your anatomy, would put you at risk for having a stroke.
Excellent. And thank you so much for sharing about SparkTool. That's a great website. I think that'll be interesting if people want to go on and check to see what their risk is.
And one thing I'll add about SparkTool is that if you take a blood thinner, it also will calculate your risk of bleeding on that blood thinner that's individualized to you. So it's very personalized, and you can input your own information. So again, it's one of those things where I think I think it's nice to deal with facts.
Excellent. Thank you. Thank you so much for being here today, Dr. Gheewala. This was great information, and I'm thrilled that we were able to bring this presentation together, even with our technical challenge in the middle there. So thank you again, and we'll see you guys all next time.
Thank you, everybody. Thank you for joining us.